talk about life. Let's have a conversation. Let's talk about life. With love and information. Let's talk about life. And let's talk about love.
Good morning. This is Valvalie Harity broadcasting from beautiful St. Petersburg, Florida. I'm so excited about this show because we're going to be following the last week's show on emotionally abused children from dysfunctional families. We did all kinds of information got shared last week for the listener so they can begin to start comprehending the scope and the nature of the problem, which does include the latest research on DNA, trauma being having the ability to affect a DNA and be actually passed down to your children and your grandchildren without intervention, of course. So that's huge news. That's about 3 years old, but it hasn't been internalized or incorporated, to my knowledge, into the treatment field, except for my guest today, who was one of the few people I've spoken to that actually read the research years ago when it came out and took it seriously and understood the implications. And that's really big. I mean, you can read anything, but to be able to understand it and apply it, that's a whole other animal entirely. So I'm very happy to have met him and to have had a common bond in this, the research knowledge and the implications involved. All my life, I've done research on adult children of alcoholics, and he's done research on children of alcoholic, dysfunctional, damaged families. It's all kind of one big Gordian knot, which, by the way, a Gordian knot is a knot that's very difficult to unravel, if at all. So it kind of is a good metaphor or symbol for the scope of the problem. My next thing I want to do is thank you, United Parcel Service and Second and Second South, who is going through their ordeal by fire today because the Grand Prix starts today, and it's a block from the Grand Prix, so the whole neighborhood sounds like buzzing wasps, the wasp nest. That's exactly what it sounds like. So they're do a tremendous job. They're open now on Sundays, by the way. They're expanded their services. Anything you could conceivably want, not to just send, but passport photos, mailboxes. They have resources everywhere. They can do just about anything you want in terms of personal and professional services at UPS. So please, it's at 2nd and 2nd South. We all know it. It's a cornerstone and a mainstay of the downtown community. So I just wanted to thank them for being my sponsors for this show, taking that leap of faith when I started my own show. So that's what I wanted to add right now also. So I want to also let you know at the end of the show, I'm going to be offering a chart on mental health. It's a chart for parents, caregivers, grandparents, whomever is in the care, taking care of a child, has a child in their care. I will send it to you. If you send me your email, I'll send it to you as an attachment. So wait till the end of the show and I'll get you that information. Last show, here's a summary of last show. Jim Lewis, who's the expert, the neuropsychologist, an expert on children, and I both presented our perspectives on here's the problem. Here's what happens if you're from an alcoholic, dysfunctional, challenged, toxic, whatever word you want to use, family system, where coping skills are minimal, where resources are nil, where children sort of have to raise themselves, or worse yet, raise their parents, and be a childless parent to parents. All these things happen in these systems. I did my research. I did 2 major researches. and that was presented in last week's show. The big research, the adult children of alcoholics, their profile, if you will, or their character traits or their inclinations, and that had 532 people in that particular research. It was divided between alcoholic ACOAs, adults from alcoholic families that are also alcoholic but are in recovery. That was mandatory in my research. And then non-alcoholic ACOAs, who wind up in my research to be kind of the primary caretakers, or what we would call today the codependents. So that was my big research. Out of that research came emotional abuse as the primary consideration for everybody. 98% of my population stated they had emotional abuse, they experienced emotional abuse. I then took that and separated out the recovering alcoholics and the non-alcoholics and found out they cross-referenced each other except for one significant area. The alcoholics had experienced greater physical abuse. So that was my research, and the thing that jumped out at me was, well, what's emotional abuse? How do we define it? And that became quite the challenge. Now, I'm going back a while. I mean, my practice, I've had a practice for over 30 years. And I was in the beginning, but, maybe there's other stuff out there now, but I'm very happy with what I learned, and I feel confident of its strength that it would stand the test of time. What's emotional abuse? Well, first of all, I found two sources. And so I had to build my questionnaire on emotional abuse based on only two research papers. One was from New York and one was from Canada. And these women had taken it upon themselves years ago to research children of alcoholics because they were involved in social services. So I had that research, and that was like a good place for me to start. Anyway, emotional abuse in many, many ways is much, much more difficult to deal with for the child than physical abuse because they can't articulate what's happening in their world. They have no language for it, just as I did when I was starting to research for it. I said, well, what does this exactly mean? I'm not going to go into the whole research, but we will send it to you. You can listen to the first show, part 1, and you will hear it. But basically, the 3 criteria for an emotional abuse, or any kind of abuse actually, is frequency, duration, and intensity. So think about, the death of 1,000 razor nicks, or the drop of water that eventually wears down a stone, and the intensity. Think about a cyclone being caught in a tornado or a hurricane. So those give you an idea of how they're measured. Those are measuring tools. And you put that together with coping skills or the lack of coping skills, and you've got a real problem for the child. So I just wanted to let you know and tell you what we did last week. Jim came on board and talked about his experience and his research treating children. I've been doing adults. He's been treating children, and what he learned and what he's convinced of, and where his area of expertise is, and how the clinical approach he takes, the compassion he shows, the understanding. But he also shifted the emphasis to the parents who pass along these behaviors without consciously knowing it. So we have, throughout the theme, by the way, of both our researches, in the background is unconsciousness, just not having a clue, and parents doing crazy things, not realizing the permanent damage that they're passing on, often because it's been done to them, and they think that that's normal. So we have a theme of unconsciousness and a theme of believing what's normal, which isn't normal. Now, my research with the adults, way up high in the top 10 list of problems, was they don't know what normal is. And that right then and there is a huge problem. So people pass on their family toxic behavior unconsciously. Nobody is plotting to hurt their child or plotting to undermine them or plotting to emotionally abuse them. This isn't some plot. This is some unconscious behavior passed around through generations often. Generations. I could tell you a million stories, and I'm not going to today, but trust me, it's a common thread in many families. So Jim wants to talk about that. That's really important because both of us started talking about where's the interventions? How do you intervene in this system, especially if we have DNA impact, genetic shifting, so to speak, genetic damage, I don't care what you want to call it. It's there. We know it. Research proves it. I'm no doubt in my mind. It makes a lot of sense to why some of this is going on because it's a hardwire now. It's in your genes, for God's sake. I mean, let's try to wrap our heads around that. That's big. That's really, really big. And I mean, it really implies that nobody's born equal. You're carrying these genes with you, like the color of your eyes and, your height, color of your hair. It's in your genetic code. How do you turn that around? That's the key question. We're going to try to answer that today. And Jim's going to do most of the sharing because that's his cup of tea right now. By the time my clients come along, they're out of childhood. They're carrying around a wounded inner child that they don't even know they have. And they're carrying around the toxic family belief systems. It's a huge problem. But it's a problem that is not beyond repair. And hell, if we can put a man on the moon, if we can send a car into outer space, if we can explore Mars, for God's sake, we can do this too. We just have to shift a few gears and come back down to earth and take a look at our kids, our system. I'm going to say something that's not going to be popular right now. When I saw that they were doing fire drills for shooters, they were doing emergency drills. Jim, what did they call them? The schools were setting up
school shooter drills.
School shooter raid drills. And I realized some of these kids were all they were doing was traumatizing these children because these children they don't get it yet. And it's hard to do something over their head like that, to pretend there's a shooter in the building. Kids and their imaginations, that's damage to me. So I read about that. I was very much against it. That's just me. That's my voice. I like to be heard, as you can tell. And I hope that they'll rethink doing these drills with these little children. They're all crying. They're all terrified. They all want their mommy. This isn't right. You're not supposed to traumatize kids, in the school system. They don't mean to. This is one of these best intention things that goes awry, The consequences of the best intentions will not be what they hope. So this is my opinion, 100% mine. I'm putting it out there. I'm hoping a voice will be heard. My voice will be heard, or rethink this. People will rethink the age that they're going to do these drills. And so I'm putting that out there because I had a very strong reaction to that when I read the article about a teacher wrote what it was like for her children to go through this drill. And then the principal comes in and says, okay, all fine. Well, that's totally uncool to me because they're too young. We have to think about age and coping and frequency, duration, and intensity. Some kids, all you have to do is scowl at them and they've got the lesson, Then the next thing you know, if that doesn't work, you raise the stakes and, you've got to rethink all this. Really. Okay, that's my 2 cents. I'm going to introduce Jim, who is brilliant and passionate and committed to his task in life. And Dr. Jim Lewis, better known as James, if you're going to Google him, he's a clinical neuropsychologist. He's got 40 years of experience conducting neuropsychological evaluations. He's going to tell you when he starts what exactly that means. He's trained in both adult and child clinical neuropsychology. He's a senior clinical neuropsychologist at Central Neurology of St. Petersburg and the Florida Children's Medical Services. He's a consultant there, for the Pinellas County Child Protection Team at the Suncoast Center. So he carries a lot, not only a lot of knowledge, he carries a lot of weight. He can make a difference. I can say whatever I want on the show, but I'm not out in the field with children like Dr. Jim is. He's conducted over 5,000 evaluations of children and adults affected by trauma. Now, we're talking about emotional trauma. That was never part of the game plan years ago. It was just, how bad did your father beat you, we're talking that slippery, evasive, emotional trauma. And that's a challenge. Neglect, exposure to parental caregivers, alcohol and substance abuse, domestic violence, chronic mental disorders, bipolar disorders that, if untreated, impact everyone in the environment. A key focus of Dr. Jim's professional and community education has been how to recognize and break the cycle. We're talking about breaking the cycle. We're talking about shifting and changing gears. We're talking about mastery over the parental behaviors, knowledge, awareness, and how to apply that awareness. So he's going to talk about breaking the cycle of parents and adult caregivers who unwittingly are re-traumatizing their children and the children in their care. Unwittingly, that's the key word. For me, I'm a little more aggressive. Unwittingly means, hey, get a clue, get conscious, pay attention, and start looking at your own childhood and your own family systems, and do a little history and see where you've suffered and what you're passing on. You aren't even aware of it. I feel that's my 2 cents. And now Jim is going to jump in with his 10 cents. So here is Dr. Jim. Hi, Jim.
Hi, Velva. Thanks for having me back again today. So Velva was mentioning how emotional abuse is so pervasive, and this is important to grasp. Why is emotional abuse the most pervasive of all forms of abuse that we're carrying around with us? It's because emotional abuse can occur by itself, where there's no other form of abuse going on, physical or sexual abuse or neglect. But in all cases of physical abuse, there's also emotional abuse. In all cases of sexual abuse, there's also emotional abuse. So emotional abuse not only occurs by itself, it is a in quotes, partner to all of the other forms of abuse. So any time children are being beat or they're witnessing domestic violence, they're being emotionally abused. If they're being sexually abused, they're being emotionally abused. And people listening to this broadcast could be thinking, well, some of this happened in my childhood. You may have tried to block it out. Blocking out never works. Facing up to it is what works. And today the focus is going to be on hope.
Okay, Jim, I'm just going to jump in because
Sure.
I promised my listeners that you would define neuropsychological evaluations and if you would share with them define it and then briefly share how it's conducted, that would be very helpful.
Sure. We discussed a little bit of this last week. What a neuropsychological evaluation is, we're assessing the functioning of the brain. Neurologists look at brain damage, structural damage, diseases. But what neuropsychologists do, we focus on how are any of these conditions, concussion, prolonged trauma, PTSD, even more commonplace things like seizure disorders, that sort of thing. How is it affecting function like memory, intelligence, verbal and nonverbal ability for children, how they're functioning in school? So neuropsychologists are administering tests and interpreting tests that tell us how the child's brain or how the adult's brain is actually functioning. What are the high areas, what are the low areas, and how can we identify these and help the adult or child function better? And that's where we get into the hope part. Listening to last week, it can be very daunting when you start thinking about, I'm carrying around all this stuff from my childhood. It's not only deeply ingrained in my brain. We discussed how the research shows that, DNA is something that codes information and stores information, but also codes and stores traumatic information. And so we're carrying this around. And now we're hoping that the people listening, that we are all focused on what do we do about it. We don't want to just keep doing this, wittingly or not. We want to make some kind of change. And at first I thought, well, what's the first step? The first step is being aware of what we're doing. And I thought about that for a minute. I thought, you know what? That's not even the first step. The first step is willingness. We have to first become willing to be aware. You know, a lot of us have tried to talk to people, argue some kind of a point, and we can make the greatest point in the world. And if the person doesn't want to understand and they're not willing to grasp it, you're not going to get to the stage of awareness. So the first thing we have to do is say, I am willing to face this. I am willing to see what might be uncomfortable, you know, about what happened in my family or what I'm doing to my own family. And then we get to awareness. Awareness is, okay, now I can become aware. When I talk this way or act this way, these are the things that I'm doing to hurt the people around me, my spouse, life partner, children, other family members. So along the way of willingness and awareness, what has to be happening virtually constantly in order to keep moving forward? Self-forgiveness. Many of the 12-step programs, certainly Codependence Anonymous, but I believe the other 12-step programs as well that deal with emotional abuse too, always want the person to be self-forgiving. Once we become aware, oh my God, I've actually hurt myself or I've hurt other people around me even though I didn't mean to. If we're too hard on ourselves, we don't move forward. We're actually re-abusing ourselves in a way. So we have to be willing to be self-forgiving. And Velva wants to jump in with the point.
I have to make a point about the inner critic because there's something called internalized. I've just lost it. It's some clinical name. For your purposes of listening, it doesn't matter exactly what the name is. But what it means is that all the criticism we've heard as children begins to become internalized, because that's what kids do. They take everything their parents say very, very seriously. They internalize it, and suddenly they have the parent, in a way, living inside of them. It's called parental introject. So people beat themselves up and possibly unwilling to listen because they either feel hopeless or they're still stuck with their inner critic, and the inner critic has a larger voice than they do. Is that fair to?
That sounds great, yeah. So the idea is to be able to overcome these cycles of abuse after we become willing to face it, and we want to become aware in our daily lives how we're talking to people, how we're dealing with our children, how we're dealing with people in our families. And as I said last week, even are we being mean to a waiter or a waitress or a flight attendant? We don't want to be overly hard on ourselves while we're trying to work through this. So what are some of the first steps? One thing that's come up repeatedly when I'm dealing with children who have suffered emotional abuse and now they've become parents, if you are a parent and you want to take some specific action, what are some behaviors that you can change fairly immediately to prevent re-traumatizing your children? And that is no hitting. Why am I saying no hitting? Well, first of all, this isn't a political, religious, or social commentary on whether it's okay to use legal spanking or legal corporal punishment. This is about something totally different. Here's the real issue. Children who have experienced any form of emotional abuse respond very differently to physical punishment than children who have not experienced emotional abuse. And how is that? Children who have experienced emotional abuse, even legal spanking, legal smacking, legal corporal punishment, it makes them worse. What it's doing is triggering whatever PTSD or whatever trauma that they have. So from the standpoint of the parent, two bad things are happening if you continue to use any kind of physical punishment with the child. You're making the child worse, and what happens is it's making it worse for you, because when the child is worsening, their behaviors get worse. They're taking it to school, they're acting out at school, they're hitting at school like they get hit at home, then you get bad notes coming home. So mom and dad aren't making it better for themselves to continue to use physical punishment with children who have had any kind of emotional abuse. So that's one of the very quick things. Most of the time, to change the patterns of emotional abuse in our life, there's no quick fix and there's no overnight change. But there are some quick fixes, and this is one of them. We make a decision that we're going to use only non-physical forms of discipline and correction with our children. I heard a speaker once talking about the word discipline, and I see kids and I say, what do you think discipline is? Oh, when I get a spanking. Discipline actually comes from a Latin word meaning to teach. So disciplining actually means teaching. How do you correct and teach somebody? So I hope I've made that point clearly, that one of the very first things to change is decide, no matter what, I'm not going to hit my children. And if you're in a relationship, you clearly aren't going to be hitting your partner either, because kids seeing that can be as traumatized as if they're being hit.
And I think that one of the things that's important to understand, too, is there are parents who think it's perfectly fine because they say, well, it happened to me, and I'm fine. Well, they're not fine, but they think they are. There's that level of denial, and there's that familial patterns through generations of certain kinds of punishment. And so sometimes when you run into that blank wall or that resistance, it's generations of behavior that you're facing. And what I do often is I'll start talking about the grandparents. I'll skip the parents, and I'll go into, well, tell me about your grandparents. And you'd be surprised what they're willing to share about their grandparents that they're not willing to share about their parents. So that's something that could be helpful. If you're looking at your family history, don't look at your parents, look at your grandparents, and start there. And you might learn a few things and understand what you've inherited that you're not aware of.
You know, coming from a background that I'm still involved in this, I don't do as many evaluations as I used to. I started out in the greater Washington metropolitan area, worked in the mid-Atlantic states, and in 2010 started working more in Florida. But out of the mouths of babes comes some amazing wisdoms. I was sitting with a 5-year-old child a few weeks ago who is just so troubled, very disturbed family background, removed from both of his biological parents. Mom was using alcohol or drugs during part of her pregnancy, said the child's brain was affected by fetal drug and alcohol exposure. 5-year-old child through 12 foster homes, couldn't make it. They're ready to get rid of him because of the acting out is so bad. And we want to try to get this child adopted because the parents' rights were terminated. And I'm sitting with the little 5-year-old. I get all my testing done so I can see, verbal skills are okay, has learning disabilities, ADHD. I asked the child, I said, what do you think's going on when you're going to school? And this is his exact words. I think I'm mad all the time because I came from a mad family. And I said, well, how do you know, you're from a mad family? He said, because all they ever told me was how bad I was. So this child associated, if I'm being hit, that means I'm not doing bad behavior, but I'm a bad person. So I think we've, kind of hammered that point home about anybody that wants to overcome the effects of emotional abuse in their lives and not pass it on to their children. Number one, find different ways of expressing yourself other than hitting. And really importantly, no hitting with the partners. If a spouse or a living partner, children are witnessing their parenting caregivers striking each other, that's nearly as bad as hitting the child.
That's amazing. That's amazing information. I'm sitting here in awe of what I'm hearing. Oh, thank you. Thank you for this. Thank you.
I mean, I'm hearing it from children telling me this, and it's really awesome to be able to sit and listen to a child. They're teaching me as much as I'm teaching them. So what are some other things that come up very frequently in people who are at this stage of awareness and willingness? What are the things? So and it gets to, Velva called them interventions. So what are these interventions? What's the second step? Okay, here's the different types, categories of interventions. And I'll say them and then go through them. 12-step programs. Some children and adults need medications for certain reasons. Different kinds of counseling and psychotherapy. So let me do the 12-step programs first. Obviously, these are not for children. These are for adults. Most of you have heard of the 12-step programs. The first one was Alcoholics Anonymous. Then Adult ACOA, which Velva's had a lot of experience with. There's almost a 12-step program for everything you can imagine. for Gamblers Anonymous, Overeaters Anonymous. But Codependence Anonymous is a powerful 12-step program that's specifically targeted emotional abuse. Anything by Melody Beatty, Beatty, is about dealing with emotional abuse and how to overcome it.
Mm-hmm. Narcotics.
So, and Narcotics Anonymous, of course, too. So the 12-step programs. So then what? Let's talk about medicine and therapy for a second. I'm going to do medicine last. And Velvet can jump in on this part too. There are people that I have seen, both children and adults, where certain types of counseling and therapy for children and for adults who are in therapy because the root of the problem is trauma. Sometimes therapy can be worse for them than not going at all. Why is that? If you are a child or you are an adult whose problems, whether it's a mental disorder, alcohol or substance abuse, domestic violence, and you've realized I need help, and you say, well, I'm just going to look up in the Yellow Pages or get a referral or go to the local mental health center, unless you go to a therapist who has been trauma trained. There are even specific programs now called trauma-focused therapy. This comes up in the child welfare system constantly, of how badly we need mental health therapists who have training in how to deal with trauma. And dealing with trauma means helping the child or adult actually talk about what happens. One of the best professionals that I ever worked with, it was after my internship at the Miami Veterans Hospital years ago. I worked in Dade County and then Broward County at the Henderson Mental Health Center. And there was this wonderful gentleman. His name was Dr. Dan Jackson. I'm not even sure if Dan's alive anymore. I met him in the mid-'70s. And I said, well, what's trauma therapy? Because he was trying to teach me how to do it. And he said, well, you have somebody comes in, say it's an adult that's been traumatized, physical, sexual, emotional abuse. They're used to blocking things out, which means they're acting it out instead of talking about it. And he said, I would have the person come in and say, write down a list of 5 or 6 or 7 or 8 things that you absolutely want to avoid talking about. And so they'd write the list up and they'd hand it back to Dan. And then Dan would say, okay, here's what your therapy's going to be. We're going to talk about everything on your list. And the person's looking in shock, like, well, I just told you these are the things, there's no way I can talk about them. And Dan would say, you're going to get power over these things. And the way you're going to get power over these things is get them out of your guts, have it come out through your mouth, through talking in therapy, and not acting it out in your relationships, even as Velva said, unconsciously. That takes a special kind of therapist. It doesn't take a therapist that you walk in the room and they say, oh, Susie, how are we doing today? How are we feeling? You know, what's going on? That's very a passive form of therapy. That does not work with children and adults who have had significant psychological and emotional trauma. So that is a crucial point to make. And I've seen kids who have been to dozens and dozens of therapy sessions and multiple therapists, and adults who have been multiple therapists. I sit with them one time to do a several-hour evaluation where I get all my tests done. Then I'm doing a trauma interview, and I'm getting them to tell me things. And they'll tell me something, I'll say, what'd your therapist say? Well, we didn't talk about that. What'd your therapist say about this? We didn't talk about that. And I start to realize that they just haven't been to people who had trauma training. So what does that mean? The therapist has to have the guts for it. The therapist has to have not just the training for it, they have to have the stomach for it, they have to have the heart for it. It's not easy for a therapist to say, okay, we're going to talk about, you know, how your daddy came into your room and did these things to you and touched your private area, or you walked in and saw your parents doing these horrible things. And so, Velva's pointing out this idea of like, what's tough love? Really, the first person, the therapist has to be tough with themselves. They have to be able to say, I want to work with people who have been traumatized, which means I have to deal with any trauma in my own life first, which some therapists don't want to do. Some people go into mental health therapy because they've had trauma and they think that just becoming a therapist is going to make it go away. But there's plenty of really great therapists out there. Tough love does not mean that we're being mean or nasty. It means more firm. We're being gentle but firm with ourselves and gentle but firm with the people around us. And certainly in the therapy sessions, we're trying to teach both the parent and the child how they can speak about things. And the more children speak about what their traumas are, the less likely they are to go act it out in school, like through so-called lesser bad behaviors like flipping the desk over, yelling at the teacher, or more acting out, which we see all over the news these days. Children are acting out trauma by killing people, shooting people, stabbing people, engaging in becoming violent criminal offenders. In the juvenile justice system, people have estimated 80 to 90% of juveniles that are in the juvenile justice system have some form of PTSD that has never been dealt with. So Velva wanted to jump in again. Go ahead.
What came up for me was an image that is incredibly helpful in terms of, and it's called Standing in the Fire. And it was a woman who wrote a poem years ago that I read, and the first question she asks the reader is, can you stand in the fire with me? Mm-hmm. And I think that's a great image for what the therapist, the parent, and the child have to stand in the fire together. They have to be able to tolerate the heat. They have to be able to hold the sentence, to center, to be stalwart and firm in, the situation and within yourself. You can't be the reactive person. So I like to use that image a lot. I'll say that, can I stand in the fire with this person? Can I tolerate what they're going to tell me? Because it's going to be horrible. And sometimes as a therapist, you have to step away once in a while and take a little break. A lot of strong therapists, they will only see so many trauma victims. So they don't feel eventually being traumatized. But there's the idea of standing in the fire. I like that image. And that's what Jim does 24/7 with his tiny, wounded, heartbreaking little clients. And that's very hard. That's another reason a lot of people don't work with kids. It's too painful for them. But standing in the fire is what I see Jim doing with these little people that need to heal so badly.
And that's a real mouthful. And I believe, as much as that is so gratifying to hear compliments like that, I believe that what I'm doing, anybody that wants to can do the same thing. Not just professionals, but parents can do it with their children. So a little funny story. These courts get my reports. These judges and magistrates get my reports, and they read them, and they're going, you got more out of this kid in one visit than they've told any therapist for the last 5 months or 2 years. And so I found out that behind my back, not in a bad way, they started calling me the child whisperer, that I could somehow get kids to talk to me. And I started thinking, what am I doing exactly? And it's what Velva said. When I am with this child, and if you're an adult and you've dealt with your own mess and you want to help your child, what I'm doing is I am fearless. I am not scared of what happened to them. I'm not scared about what they're telling me. I'm not anxious. If a kid picks up that the parent or the therapist is nervous or anxious or flinches about what they're discussing, the kid's going to clam up. And parents can say all day, well, tell me what you're going through. But if the child picks up, if I tell my mommy or daddy what I'm going through, they're going to flip out, or some kids have told me, I don't tell my mommy what I'm going through because it's going to just make her sad, or it's going to make them mad. So they keep it inside and then they go act out somewhere. So adults who want to help break the cycles of abuse with their children. So all this stuff about 12-step programs and therapies. So then I said I would mention about medications. This is a huge, big deal in our culture. What I actually see is, I've spoken on this at national conventions, I see what is called the two epidemics of medication. One is over-medication, and another is children or adults who may need some low-dose medication support that aren't getting it at all. So people who are eligible and could benefit from some small amount of medicine versus people who are over-medicated. Kids are over-medicated sometimes because of ADHD. The most common form is hyperactivity. That's most visible, but there's another form called the predominantly inattentive type, where the child is more depressed than overactive and can't concentrate. What's that got to do with trauma? Kids who are traumatized can have symptoms of ADHD. Kids who are born from parents who were traumatized and used alcohol or drugs to cope with their trauma. Now that mom's carrying a baby, maybe mom quit drugs, but only after the second or third month when she knew she was pregnant, so the child was fetal drug exposed. That child has a risk of becoming ADHD or learning disabled. So what is the point of, if medication is indicated for attention disorder, for depression, for bipolar, for really any condition? And this is from pharmaceutical research. The pharmaceutical research that has to be produced to the FDA to get approval to sell a drug, in almost every case, medicine is supposed to be, this is the word that's used, an adjunct or supportive remedy. That's what it's supposed to be. An adjunct remedy is a remedy that is supporting other forms of therapy. So that's just absolutely critical to grasp that point. It is never supposed to be the primary remedy. We do not want kids just to be medicated with nothing else being provided. We have to be very careful when we work with our children's school, because the easiest thing to do is not the best thing. The easiest thing for a parent sometimes, when I say easiest, what takes the least work on the part of teachers and parents, well, give Johnny or Susie a medicine and we don't have to do anything. That is not often the best thing to do. The best thing to do is what are called non-medication remedies. These individual and family therapies, kids who have attention disorders or learning disabilities at school, which is not uncommon in children who have been growing up in emotional abuse situations, they need to have educational supports. Parents need to know how to go fight for an individual education plan or something called Section 504 accommodations. So once you have these other remedies in place, the children are going to be on less medication, on lower doses, and have less side effects. So it's important to avoid these extremes. These extreme is, I'll never use a medicine for myself, I'll never use a medicine for my child, and then the other extreme is, medicine's going to be my first resort. Both of those extremes should be avoided. And just like you would need to find a therapist who focuses on trauma, if you are an adult or you have a child who needs medication, you want to find a doctor who has a conservative medication philosophy. And I just want to say a word about that. I'm going to let Velva jump in.
I'm not jumping in.
Oh, I'm sorry. Okay.
Okay, go ahead.
What's a conservative medication philosophy? It's very simple. The lowest doses of medicine with the fewest numbers of medicines possible. We have almost an epidemic in our country of children with behavior disorders that are being medicated with drugs called neuroleptics. They're the same drugs that were developed for adult schizophrenics. They're being used with children for behavior management because it basically calms them down. Some kids say that it dopes them up, that it takes their energy away and they're not acting out and becoming behavior problems. But they're very risky medications. There's children who need these neuroleptics like Risperdal, things like that. But there's other cases where what's happening is you're using a medicine to treat the behavioral symptom, but the underlying trauma isn't being dealt with.
Perfect. That's perfect. We are going to take a break right now because I really want to go back to this medication issue, and we're going to reframe it, and Jim and I will have a dialogue about it, and I will be asking him questions that you possibly want to ask him that, right now it's not possible. Just remember, you can email me any question you want, and I will gladly forward it to Jim, VLHERATY@gmail.com, and just shoot me an email with a question. We're going to take a brief break now, and we're going to come back, and we're going to continue the medication. But I think I want all of you to sort of start to internalize some of the things you just heard, and we'll come back and think about questions. And, we can answer anything. Between Jim and I, I'm confident we can answer to the most degree possible any questions you may have. So take a break. We're going to take a break. I'm going to play the theme song. And while the theme song is playing, I want you to make some notes and think about everything I just heard, especially about drugs. I'm shocked that they were giving the same drug to children that I remember in my training was the primary drug of use for treatment for schizophrenics. You know how strong those drugs are? We're going to come back to that. We're going to take a break right now.
Let's talk about life. Let's have a conversation. Let's talk about life. With love and information. Let's talk about life. And let's talk about love.
Okay, that was our little musical break. I love that song. It really brings my spirits up when I hear it. That, by the way, that song was donated by Neil Van Eerd, a stellar musician from New York who offered to do the theme song for this show. Okay, we're back. We have some time, and I think it's time to start a dialogue about drugs. I have a bunch of questions that I want to ask him based on what Dr. Jim just shared, and I'm encouraging you to send me questions that I can pass along. But this medication thing is incredibly, I think it's a cultural imperative that we go first to medicine. That's just the way we're set up culturally. As I say something, I remember years ago, I'd say, gee, what did the doctor say? Was always the question my ex-husband asked, what did the doctor say? Like, I didn't know my own body or I didn't know my own feelings. So this is part of it. There's a knee-jerk to the medical, to go to look for medicine as the first response. It's cultural, but it's also obviously family systems. I know certain cultures lean much more towards legal drugs than, doing a joint or, popping, having a drink. So there's the pill popping cultures, and then there's the drinking cultures, and but the bottom line is they're all coping skills. They're all a replacement for learning to cope. So having said all that, I want to talk to Jim. I want him to be kind enough to go back to this idea of an overstressed school system, a panic in the community about drugs, the alarming death rate of opioid users. There's a drama, a cultural drama being created, not just by the media, but, we now learn about pill mills. We now are hearing about doctors who are not in the business of healing, but in the business of prescribing. And they're two very different businesses. So the prescribers, all they do is write script. It's all they do is write script. And you've got to know who those people are. You have to. But if that's what you want, that's part of the problem. The culture created the reaction, okay, I'll take a pill. It'll all go away. And that's where our head is at. So, of course, the greedy doctor is going to follow. Well, if they want pills, I'll give them pills. And, they prescribe, an extraordinary amount of pills, and they become a pill mill doctor. So how does one begin? I think you can begin by listening to this information, by deciding, okay, what's my first knee jerk? How about doing some self-evaluation? When I have a headache, the first thing I do is take a pill, or do I lie down and rest for a while and with a cloth on my head? There's lots of ways of coping. And I think we're slowly, as a culture, turning to other ways. But we don't think of that when we think of children. We don't tell children, lie down, take a nap, and everything will be better after a nap. There's ways there's ways we can do this. So I'm going to defer back to Dr. Jim and talk about how we can get out of the mindset or the hardwire of writing a pill, especially when we're stressed ourselves. And school systems are stressed to the max. They're not functional. You can listen to the song "Just Another Brick in the Wall," by Dark Side of the Moon, and that says it all. And that hasn't changed as long as I've been around. So let's talk about that, Jim. Talk about how to heal more than one system, how the child can be healed through the system's healing.
Okay, so in the few minutes that we have left, I'm going to divide this into medications with children and medications with adults. Here are some simple facts about medicines with children. Even though I did describe a minute ago that there's these powerful drugs called neuroleptics that are used with children with behavior problems, there are certainly kids who need that medicine to function. However, there are almost no cases where the solution for the child is only a medication. That's the issue. It's not medicine or not. It's if you are using a medication and it is indicated at the lowest dose possible, what else does the child need? So what are the four things that go? Medicine, these are remedies. Velva started the show out talking today about interventions. How do we give hope? How do we change things? Medication, educational remedies at school, kids getting special help. Florida calls it exceptional student education. Other states call it special education for emotional behavior disorders, learning disabilities, attention disorders. So medicine, educational, psychotherapeutic remedies. We've already discussed that. And what's the fourth prong here? Home environment. Calm home environment. So you could be doing medicine for the child, educational remedies, you're going to therapy, and the kid comes home and mom and dad's living partners are fighting like cats and dogs. You just undermine the whole system. So it's all got to be, these are called concurrent remedies: medicine, educational, psychological, which is therapeutic, and home environment. I want to go ahead.
What happens if you've got let's say you don't have the conflictual home environment, but what happens when the kid's sitting in front of one of these games where everybody's killing each other? And, their world is inside this virtual world of violence and aggression. I mean...
Right, that wouldn't be a calm home environment. The child being exposed to... Those things energize the part of the brain called the limbic system, which is the fight or flight part of the brain. So it's just good common sense. If children are in front of these hardcore killer video games all day, what does it mean they're not doing? They're not playing with mom or dad or their caregivers. So let's flip over in the few minutes I have left. As I promised, I would talk about medicines with adults. And Velva brought up the opioid crisis.
We can run over, by the way.
Okay, and that's fine. I find this to be true unquestionably many of the times that I'm seeing adults who are using medication. Here's what's happening primarily with narcotic painkillers, but things related to narcotics like overuse of Xanax and anti-anxiety agents, not at low dosage to manage a true anxiety disorder. What is actually happening when adolescents or adults who may initially need a narcotic painkiller for a true pain disorder, broken leg, dental problem, a broken crown, something like that, how does it end up turning into opiate abuse or narcotic abuse? It's very simple. People are using narcotic painkillers to numb psychological pain. And guess what? It never works. So the adult, this whole show, 2 series, has been about emotional abuse. So we have the adult who had physical, sexual, emotional abuse as a child, carried it into adult relationships, maybe got re-traumatized again in domestic violence relationships. And now this adult is using a narcotic medication, maybe initially legally prescribed, and they start overusing it. That is often an adult who is using the medicine to try to numb or calm or block the psychological pain. It'll never work. What do you do to deal with psychological pain? We talked about it. Trauma therapy, the 12-step programs, non-medication remedies. So the great addictive society is very often adults who have these traumas that are not being dealt with and using drugs to cope with the trauma, and it's not the way to go. Here's another side problem. The drugs themselves can produce things that look like mental disorders. So let's talk about bipolar disorders really quickly. So we have somebody who in their family bipolar disorders run, like mania, depression, and it's there, it's legit. The person really has a bipolar disorder. They need a medicine for it. They need counseling and psychotherapy. There's many patients, adults who have bipolar disorders who are perfectly normal, effective, coping parents and good workers in their jobs. But here's another issue. The drugs themselves, amphetamines, cocaine, any of the psychostimulants, people who are abusing Adderall, that's a psychostimulant. On the other end, the depressants, alcohol is a central nervous system depressant. The anxiety agents, overuse of Xanax, things like that, Valium, those are central nervous system depressants. Oxycodone, all the narcotics are central nervous system depressants. What do these things cause? They cause something that we have called substance-induced mood disorders. So we have two people with exactly the same symptoms, walks into a primary care doctor, walks into a psychiatrist, doesn't talk about their trauma. Both people look like they have a true bipolar disorder. One of them has been substance-induced, that they're having the symptoms because they're flip-flopping back and forth between a downer or a narcotic to cope with the psychological pain, but then they're too dopey, so they're having to use a stimulant to wake back up and get energized again. And they're going back and forth in this cycle that looks like a bipolar disorder. What's the treatment for substance-induced mood disorder? Not bipolar medicine. The treatment for substance-induced mood disorder is quit, is abstinence from substances. No meds, no drugs, no substances, no nothing. The treatment for a true bipolar disorder are low doses of bipolar medicines. What do I mean by low doses? The lowest dose possible to manage the condition. So what I'm describing to you is very rampant in our culture. This idea, and substance-induced mood disorders are often overlooked by psychiatrists, by primary care doctors. They're occurring invariably in adults who have some kind of emotional abuse, physical, sexual abuse in their own history, and they're using medicines to cope with it.
That's fabulous. That's fabulous. Now, I want to just ask you one question. We need to end the show, but there's one question that I think I'd like to end the show with. When you say just quit, now I know from my research that there's cellular adaptation for a substance abuser and alcoholic, that if they drink enough and put enough alcohol in their system, they will have cellular adaptation, which creates the addiction. Mm-hmm. So, what is the very, very first step, no matter how small, somebody could take to get out of this cycle? Just one step, maybe two if you've got two, but something simple and manageable for somebody whose heart starts to race when you say just quit. People that have tried unsuccessfully, people that have repeatedly, relapsed, people that haven't a clue how to quit. Their whole world has just been about, numbing their pain. I'd like you to take your time, but just keep it real simple for my listener. How do you just quit?
Well, this is a great point. So, first of all, we go back to the very first thing that I said today, willingness. While the person's still abusing substances, the adult or adolescent, first they have to become willing to become abstinent. The second thing is get some kind of professional help. Velvet didn't say it exactly, but it was alluding to it. There are certain cases where it's not medically indicated for a person to just, as we call it, quit cold turkey. People who have a certain amount of high blood alcohol or certain substances they're abusing, if you try to quit, they can have something called withdrawal seizures. It can be dangerous. That's why medical detoxification units were set up to help people to come off of drugs under medical supervision, come off of alcohol under medical supervision.
So get an evaluation. After you are willing to take a look at this, the second thing you really need to do is pick up the phone, call a AA, ask for who they use or who they recommend for medical evaluations. Don't do it like you said. Your people have died trying to do it cold turkey. And what is it? If there's a third thing, Jim, what is it?
It would be, well, after willingness, then you go to, one of the outpatient or inpatient drug and alcohol treatment centers, and you get evaluated. And evaluated means you have to tell the truth about what your history is. You can't minimize. You have to say, this is what I'm using. This is how long I've been using it. So that's step 2, get evaluated. What's the third step? Become involved in the treatment programs. The treatment programs can be going to group counseling. It can be go to a therapist to deal with the mental health problem that's coexisting with the substance abuse, going to 12-step programs, getting drug urinalysis testing. So step 1, willingness. Step 2, get evaluated to see what kind of help you need to come off safely off of the medicines.
Yes, definitely.
And then third, get into some kind of active treatment, therapy, 12-step programs, the thing we talked about earlier.
I'm going to recommend personally the 12 steps, and I'll tell you why. 97% of the people I worked with recovered through 12 steps. Only 93, yes, only 7% went through a professional program, mainly because of money. And I started my practice when insurances covered everything. And slowly and surely over the time, they limited treatment to 10 sessions, I believe, if I recall. How do you string 10 sessions together? How do you alternate? But I would use those sessions to get an evaluation. And then the best, smartest, most practical, in a cost-effective way is to go to a 12-step program. And we can talk. Maybe we'll have another session about treatment and care or aftercare, because that's a huge part of recovery. And I'm just having emotions about this show because I think there's so much richness to it for people who are willing to take the first step. And that's up to you. Nobody can dictate that to anybody. So I want to thank Jim. We'll probably talk about doing another show because so much is coming up for me information-wise that we could share. He's just this font of, I've learned so much today. I'm so happy to have met you and to know that there's information out there and to know the type of drugs and to know the kinds of things that, as in my practice, we didn't really look at much of that. I had a source in Chicago that did the medical evaluations, and so this is incredibly rich material. The future of our children, because just like alcoholism, every acting out child affects 7 to 10 people in their world: school, home, work, play. All the resources that go to helping or calming that child in the classroom. We can make huge changes. We really can. So I'm encouraging you to take that willing step. Just get an evaluation. Just simple. Use your insurance for that. And if you don't want to use your insurance, if you don't want to be on paper, that's okay too. Pay for it yourself. Make a payment plan with a professional that, hey, here's what I want. You can get an evaluation in 10 minutes if you really want one, and if it's a matter of money. So don't say, I can't afford it. That's bull. Say, I have to do it for the sake of myself and my family. So that's my preaching. Thank you. Thank you very, very much.
It's great being with you.
It's wonderful. I'm very impressed. I want to thank UPS, Joe. You're wonderful for helping bring all this out into the world. I'm very grateful for that. You've learned so much. Reach out if you want. Let's Talk Life if you have questions. And if you want that chart that I mentioned earlier, I'll gladly send it to you. I'm going to put it on my Facebook pages too, the chart for, the kinds of things you can look at when you're childbearing. But this is the real stuff. This is the heart and soul stuff that you need to start internalizing. I'm also going to urge you to listen to this show more than once. You're going to be able to download it if you want. You're going to be able to listen to it as often as you wish. And because there's so much in here, I think it's worth a second or third listening. You can isolate sections if you want that you really want to listen and focus on. Personally, I'm going to listen to Jim again because there was so much rich material there. So, thank you for listening. Thank you for joining us. You can also share this show with others. Once you download it, the link will be on my Let's Talk Life Facebook page. You can download that on your desktop. You can send it to whomever you wish. The show is also on iTunes. So a lot of times you're going to click the link. It'll go to iTunes, and that's where the show is stored. Any questions, any concerns, letstalklife@gmail.com. Thank you, thank you, thank you, thank you. Here's Kath. Here's our theme.
Let's talk about life. Let's have a conversation. Let's talk about life.